Good evening, everyone, and thank you for being with us tonight. We'll start right away with an interesting radiographic image, which is one of the cases that Dr. Alessandro Tardani will be presenting tonight. Hi, Alessandro. Welcome. Hi, thank you, Claudio. Good evening, everyone. This type of technique is one we at Osseotouch propose, and it is certainly a technique that offers some very interesting advantages compared to traditional guided surgery. That is, the one that is based solely on the use of drills, which, however, requires a learning curve to be used to its full potential. And the task we have assigned to Alessandro for tonight is to give us some guidance on this. I have a couple of technical notes. The first is that if you have any questions during the webinar, feel free to ask them using the chat, so please ask many and make them good ones, because that will allow us to delve deeper into the topics as they are presented. The second thing is a reminder to everyone that on May 23rd, there will be a practical one-day course in Vergiati, in the province of Varese, near Malpensa, held by Dr. Tardani, and we will make all the information available for those who wish to register. Obviously, that course is meant to give you all the in-depth guidance compared to the information we'll be giving tonight. Alessandro, the stage is yours. Thanks, Claudio. Good evening, everyone. As Claudio rightly anticipated, today we'll be talking about guided surgery with magnetodynamics. So my brief presentation tonight will start right from these two concepts. So, the first concept on which we'll look at the fundamental data will be guided surgery, so the fundamentals to be able to plan and understand it, and then how to combine this type of technique with magnetodynamics. Therefore, the first thing that I always like to understand is the why behind what we do. So why it's important to perform guided surgery. Because in the majority of cases, almost half of peri-implantitis cases are linked to an implant that was not positioned correctly. So half is a high number, but above all, we need to realize something else. How many implants are malpositioned? To understand the real importance of this figure, we need to consider another figure. Unfortunately, this was provided last year at the International Congress of Periodontology in Rimini by the SIDP. This very topic was addressed, and so they gave an estimate of about 40% for the incorrect positioning of implants. And this study was conducted at a European level, so it includes a number of implants that is certainly very high and has absolute scientific value. So, what was done? Just a quick summary. This is the only table tonight, so I won't overwhelm you, but it's to explain the difference that's normally used to determine a well-placed implant versus a poorly placed one. To date, there isn't a single measurement or a single value to determine this difference, but as you can see from this series of articles I've cited, normally when there is a discrepancy of over 2 millimeters of difference between the apex or the implant platform of a planned implant and the actual implant, it can be defined as a poorly placed implant. It's been shown that with freehand placement, following the CBCT data, you get around 40%, a value that with guided surgery is reduced from a maximum of 12% down to about 5%. So we reduce the problems by at least 3 times related to the placement of our implants. So we've seen the downside. Now let's look at the advantages, the most immediate things you can see when using guided surgery correctly. The first thing, which for me is fundamental, is safety. Being sure not to approach noble or delicate structures such as the alveolar nerve, being careful in managing a maxillary, a sinus, which is certainly an area of interest for us with magnetodynamics. Therefore, using guided surgery allows us to assess the distance from the sinus beforehand and safely choose the potential invasion of the sinus itself. So we plan both how much we need to lift our sinus and the type of implant inclination that we're going to perform. Doing all this beforehand, calmly, and obviously without the stress of the immediate surgery will later lead us to perform a much faster procedure. Why? Because we've already performed the surgery when we were relaxed in front of our computer and without any anxiety. So it will just be a matter of replicating inside our patient's mouth what has already been done virtually. What does this mean in practical terms for me, but also for many colleagues with whom I've discussed this? A reduction in operator stress during the surgery. I've included this case, which was not performed with magnetodynamics, I should say, but it was the most illustrative example. Being able to place an implant at positions 6 and 7 in the third quadrant, in a guided way, so one implant in a healed socket and the other in a post-extraction socket, safely and with confidence, thanks to a surgical guide. This allowed me to dedicate the necessary time and attention to recreating an adequate depth of the vestibule in the N36 area, which was extremely shallow and unsuitable for maintaining hygiene by the patient. So, to do this, to achieve results that are always and consistently valid within a guided surgery plan, my digital technician and I created. My technician is the one who has made all the surgical guides you will see in this presentation. A protocol. Clearly, tonight, we're not going to run a full course. I'll just give you some quick guidance on the most fundamental aspect: data collection. Modern surgery in 2026 cannot avoid correctly gathering all the necessary data, which are basically three. The first and most important is obviously a CBCT, which must be taken knowing the parameters of our machines. Obviously, for those with an in-house CBCT, or in any case, you need to interface directly if you send patients to an external center. At the same time, it's also essential to take a dental impression, a wide one. And I'll tell you right now, even in this digital era, I am still a fan of a conventional impression, because the details captured with a conventional impression, even a simple alginate, are still superior to what we can obtain from a digital scan. Lastly, but no less important, are intra- and extraoral photos. Obviously, the extraoral photo becomes more valuable, especially when we are performing a full rehabilitation or one in the anterior zone, and it may lose some importance when we are doing simpler work, perhaps only in the posterior areas. So, let's get to the main point. Guided surgery. How is it performed? It's performed through the creation and then the intraoperative use of templates or surgical guides. They're made of resin, so they are printed and can generally be divided into what are called classic guides, meaning those with a metal sleeve, or there are guides called sleeveless, where the engagement and the path for the drill is printed directly into the resin itself. The difference here, again, let's look at it very quickly, because this is also a topic for a rather long debate. It often depends on the type of implant, on the implant brand we are going to use, because the various implant companies have favored one method or the other. At the same time, using both methods, we also evaluated how to create a surgical guide that is more suitable for using the magnetic mallet, and therefore a technique that is based on bone condensation rather than drilling, because clearly the stress we put on the resin with a drill compared to the stress we apply with a handpiece, like the mallet, which is much longer, are different. So, we've evaluated how increasing the size of certain parts of this guide ensures greater stability and reduces the vibration effect, giving us greater precision in more complex cases. We also know that surgical guides can be made in a stackable way, meaning composed of multiple modules, and can be designed as closed or open. In this case, and this is my personal preference, I always tend to use open guides exclusively because I see many more advantages, even though we can get the same stability and rigidity as closed ones if designed correctly. Now let's see how we can combine these two advantages. So let's look at how to use guided surgery with bone condensation versus drills. What are the differences? Probably all of you watching already know this because you're interested in the magnetic mallet. But let's do a quick summary. With bone condensation, we certainly try to improve the bone quality. So we try to improve low-density bone to turn it into a higher quality one. We eliminate the need for irrigation of the implant site, which means better visibility and more comfort for the patient, who often complains about the amount of water. At the same time, we don't risk overheating the bone we're working on, especially when using guided surgery, as the presence of the sleeves can somewhat reduce the amount of water that reaches our site. Of course, it's not one technique versus the other. They can absolutely be used together in certain situations, because if we find ourselves in denser bone, using drills is definitely more indicated. But it also happens that sometimes you can use a pilot drill first and then move on to bone condensation. Drilling tends to be slightly faster, but this is often related to the fact that most clinicians are more used to it, so greater familiarity leads to being faster when using of some techniques over others, because as Claudio rightly said, you need a learning curve for everything when you're approaching a new technique. So, let's start. I'll show you some fairly simple cases where using the mallet proved to be definitely advantageous compared to a drilling technique. So I'll show you a case of a single edentulous space in a healed site where a socket preservation had previously been performed using heterologous materials. So we find ourselves assessing bone where the cross-section is certainly adequate. We have a bone that is slightly deficient in terms of corono-apical dimension. So this is the ideal situation for using the mallet. Why? Because this way we can improve the quality of the existing bone, because we know that although radiographically it looks like fairly compact bone, the image provided by the biomaterials often looks more compact, while in reality we are dealing with bone of a rather limited quality. So we improve the quality, and that small amount of lift, those 2 millimeters or so of lift, can be easily achieved with the mallet without any particular problems. So here, in a short video, I'll show you how guided surgery planning allows us not only to position the implant, but also to evaluate it 360 degrees for a correct assessment of the amount of lift that we will be planning. So we can see if the sinus is flat or angled, and therefore we have to determine the minimum distance between the coronal and apical part to start planning our lift. And this way, we can be confident in performing it without problems, because the stops on our surgical guide will ensure the correct positioning of our osteotomes without the risk of going too deep and perhaps fracturing the sinus floor too early. As I mentioned earlier, you always assess bone density, which in this case I've already anticipated that our software gets it wrong because it sees a fairly dense material when in reality it's the remnant of a biomaterial that won't actually have, and I can confirm this clinically, any significant density. At the same time, we see how in the most apical part it indicates a very low density because the implant apex has been virtually placed inside the sinus. So here we can see the clinical images. We see our position. I've raised a flap and placed the surgical guide without any difficulty. With our mallet the dedicated stops, I reached the required depth. So following the classic technique, we stopped about 1 millimeter from the maxillary sinus cortex and then applied collagen and proceeded with the sinus lift itself. In this other case, also in the same area, we had to replace a tooth that was already lost, so clinically lost. What did this upper first molar present? Besides the loss of the crown and furcation involvement, it also had a large apical granuloma, so it was considered a non-restorable tooth, and we decided to extract it and proceed with immediate implant placement. This is because we could easily make this assessment beforehand, because using the guided surgery software allows me to segment the tooth of interest in advance, and therefore to make a more precise assessment of the interradicular septum that I will find. Of course, this allows me to evaluate it. I will then have to be careful. We'll have to be careful to properly section the roots to preserve all the residual bone and ensure the correct placement of our implant. So you can see here, we superimposed the implant on the septum, practically in the center of the socket. Here, we could have also considered placing it a bit more palatally, but in my opinion, the width of this septum allowed me to use the mallet. This is where the mallet makes the difference, because by not drilling, I was able to displace this amount of bone and obtain, as you will see later, a type A socket. So, here we are. You see the sectioning of the tooth, its extraction, so the post-extraction sockets are clearly visible. Obviously, a thorough curettage was performed to remove the apical granulation tissue at the messiobuccal root. We placed our surgical guide, which, as you can see in this case, is a sleeveless guide, and with the mallet, we completely altered the architecture of the post-extraction socket. We created a new socket for our implant placement, so we managed to have perfect bone for our implant placement, so the implant was placed completely surrounded by bone. Then, in this case, I still preferred to use some biomaterial inside the other root sockets, not to improve implant osseointegration, but for better volume maintenance. For example, this case isn't very recent. I used a standard healing abutment. Had I done it more recently, I probably would have used a custom healing abutment because it would have allowed for better maintenance of the buccal contour. We can in fact see anyway, as I told you before, in the follow-up X-ray, how immediately, post-operatively, you can barely see the root areas because they were objectively filled with heterologous material. So here is our kit. This is the famous Osseotouch kit for guided surgery, which, like all guided surgery kits, assumes that the instrument being used has sequential stops that go against the sleeve that we are going to use. And as I was saying before, I'm not against using drills, but even in the kit itself, we still find a 2 mm drill, so a classic pilot drill. Why? Because there are situations where the use of the mallet can certainly give us great advantages, but at the same time, we might still face bone that tends to become too dense, too hard, and so using a drill definitely helps us in our work. One thing I'll give you as a simple tip is that all the drills we use, even starting from a length, let's say 6 for example, drill slightly deeper, so they give us that extra 0.5 or 1, depending on the drill, of extra depth, which in some cases can ensure a greater and better expansion, so an expansion with less tension, of the bone that we will then go on to modify using our magnetic mallet. I've prepared, let's say, to give you an idea, using the black ruby as an example, a diagram of how the osteotomes for guided surgery were created. The start is almost identical, so they use the same taper for the first 7.5 mm. Then the guided instrument tends to become cylindrical to allow for easier sliding, but the difference in use is very limited. The process by which they were created still starts from the black ruby and was slightly modified to simplify the use of the calibrated sleeves that then allow it to be used in the most suitable way with our sleeves. Obviously, for those who already know, but also for those who don't, Osseotouch has created an implant that is, let's say, tailor-made for use with its osteotomes, which is the connex, which obviously has a non-working head because it's used typically in the upper jaw, so to avoid damaging a sinus that has just been lifted, for example, or to protect soft tissues or bone that isn't of excellent quality, but where we have improved its quality. So, let me touch on a bit more theory. When using the magnetic mallet, it starts from a fundamental concept. We want to change typically bone quality or preserve bone without removing it. So, the key thing to assess on our CBCT is the bone density itself. But what do we need to know? That our CBCTs don't actually give a real value. When we talk about Hounsfield units, they strictly refer only to medical CTs. Every time we apply this to a CBCT, we are making an error. This is because our gray values vary depending on the areas of the CBCT itself. Nevertheless, it's still crucial for all of us to know and correctly assess the bone before approaching it, because this prevents us from finding ourselves stuck mid-procedure with the mallet tip, unable to advance, because we've correctly identified a bone as too dense, where the mallet might not have been indicated. So, first, you need to perform the classic bone quality assessments, evaluating the thickness of the cortical and medullary bone, and then also its shape. Because another great advantage of the mallet, especially in guided surgery and in the maxillary premolar and canine areas, is that it can be used not only to improve bone quality, but also for minimal expansion in ridges that might be sufficiently long, but are often slightly narrow from a buccolingual standpoint. Clearly, in a picture like the one on the far right, using the mallet would obviously not be indicated, whereas in this next picture, the third one, which I'm highlighting, let's see if Claudio taught me correctly, here it is, in this picture, clearly is an excellent area to improve both the quality and the volume of our bone. One last fundamental thing when talking about the maxilla is the maxillary sinus itself. Very often, during our tomographic evaluations, we can see, as in this case, patients with a completely opacified sinus. And if we have to operate in that area, whether with the mallet or simply by placing an implant or performing any type of surgical work in that area, it's crucial to inform the patient of a pre-existing condition that must be investigated, because let's remember that whoever is the last to intervene becomes automatically liable for any problem the patient might have in the future. Okay, here's the image of the case we started the presentation with. Presentation. Clearly, this is a bit more complex. The patient presented apart from some endoprosthetic work on the centrals to be managed, he was missing the posterior teeth in both the first and third sextants. Tooth 25 was a lost tooth, so we decided to place 2 implants per side. You can see in this case as well the placement of a unilateral pin, because on the left side it wasn't possible to place it due to severe bone deficiency, so we didn't have enough support to place it. Otherwise, it would have definitely been more appropriate. To place 1 pin on the right side and 1 on the left. In this case as well, we perform a thorough evaluation before starting, and we assess in a prosthetically driven way the placement of our implants. So we try to position the implants relative to the final dentition we'd like to give to our patient. And from there, we see if we can place them in the optimal position and what the needs we have to address are. So we can see that the implant at site 16 would require, if we want to place it in a correct position from a prosthetic standpoint, a minimal displacement of the cortical bone and the sinus to get a good buccal aspect, but using the mallet allowed me to place it in the prosthetically ideal position with very little effort, without having to use any drills and guaranteeing a safe placement without fear of damaging the sinus in that position. On the other hand, at the site I mentioned before, for the implant in position, we are certainly facing an area where the coronoapical distance is more than acceptable, but a certainly limited buccolingual distance. Here I'm placing an implant, a 3.3 I believe, so a very narrow implant. So, in this case too, the use of a drill would have risked leaving a buccal cortical plate that was probably too thin, creating a risk of dehiscence on some threads. Using the mallet with a guide, therefore, without risking any deviation, allowed us to perform a minimal expansion of the buccal cortical plate and therefore certainly guarantee greater longevity for this implant over time. On the left side, the situation was slightly more complex. We can see that at site 24, we needed to perform a small crestal sinus lift, but this is a fairly standard procedure when using the mallet. This is the most classic use of the magnetic mallet in the maxilla. In the area of site 25, however, we found a slightly more peculiar situation. Here, before anyone asks, I'll answer in advance. The surgery was performed in a practice I collaborate with, so I couldn't choose the implant brand, because in this area, if I had been able to, I would have chosen an implant with a more aggressive thread design to ensure greater primary stability in a post-extraction socket where there was low-quality residual bone and also a relatively scarce amount of it. So you can see how we proceeded, always very gently, using our mallet for the extraction and the cleaning of the socket. In this case, we decided to place the implants flaplessly, so with a tissue punch, also guided by our surgical guide, we removed the mucosa. You can see on the right, the famous surgical guide I mentioned earlier, with the reinforcement for its use. So this slightly chubbier, more pronounced shape allows for the dissipation of vibrations in order to ensure a lower risk of dislodging the guide during use. I will then show you a video where I demonstrate how it's slightly more complex to use the mallet with a surgical guide than a drill due to the mallet's length. So here we see it in use. On the left, you can see those two colored rings that are used to add the intermediate lengths that aren't available with the standard stops. So in this case, we proceeded entirely with bone condensation. We performed 2 mini sinus lifts, and we condensed the bone in the post-extraction site in a very simple way, and above all, without reducing the risks associated with using a drill very simply. So we placed the implants, and here, as I said, being tied to an implant company that was the one used by the practice, the healing abutments were also not the ones I would have wanted to use here. It would have definitely been better to use healing abutments with a slightly wider head to better maintain the gingival profiles. Anyway, I'll show you how the fact that I was able to place the healing abutments in every site, even in the extraction socket, means that for all 4 implants, an insertion torque was achieved of over 35 N-centum in bone, where the initial density was about a D3, and definitely a D4 density in the post-extraction socket, where besides the low quality, we also had a limited amount of bone. Here, of course, some biomaterial was placed to try and maintain the volume of the buccal plate. In this case, we didn't bother placing a custom healing abutment because there was already some recession on the first premolar, so it made little sense to try and maintain at all costs that convexity related to the second premolar. This is what I was talking about. So now I'll show you a short video that shows the use of the mallet with a surgical guide. The important thing, whether you're using the magnetodynamic technique or a drilling technique, is that before you activate the pulse or the drill, we must be 100% sure that the sleeve is perfectly engaged within the guide. At the same time, you can see how, with every small pulse, a slight rotation is performed of the handpiece itself to prevent the instrument from getting stuck inside the sleeve, ensuring easier insertion and, at the same time, easier removal. This is a key detail when using the mallet with guided surgery. Why? Because, as we said before, we know we won't be using water. So you can see the patient is more relaxed, has no discomfort, because there's no water, no vibration. There is, of course, this knocking sensation, which isn't pleasant for everyone, but 99% of patients, if warned beforehand, don't complain. On the other hand, we must be careful that blood residue doesn't build up inside our sleeves, a layer that will make it harder to pass through, so using saline is always recommended. To give it to lightly rinse our sleeves, thus allowing a smoother gliding of our instrument inside the sleeve itself. Let's look at a final case to see the advantages of this method. So, we can see that in this case as well, before proceeding with any planning, we recreate virtual teeth. Here they are more colorful than my usual white ones because my son was around that evening and wanted to make them colorful. But if my son could do it, then probably any of us can manage to create virtual teeth in our software. So, what was the situation? We had a patient with a bridge, supported by a third molar and a first molar, both periodontally compromised, and in a patient who absolutely did not want to be left without teeth. So we evaluated placing 2 implants in the 5 and 7 positions, temporarily keeping the 2 clinically hopeless teeth to allow the patient to chew. At the same time, what did we do? We obviously performed an evaluation. So, what did we assess? As you saw from the arrow, we saw that in this case, the alveolar antral artery is present, clearly visible, and within the bone structure. We can see how the maxillary sinus in this anatomical area is very narrow, and so a sinus lift will surely be particularly simple in the transverse dimension. But the moment we perform this simple movement, we see that we are at the point where the maxillary sinus is in its most mesial part. So we are faced with an area that is not flat, but quite the contrary, with varying heights. So it must be approached a bit more carefully to ensure a sinus lift that is straightforward but risk-free. So it's not a case to start with, not a case for a beginner of this. As for the more distal site, however, we find a completely opposite situation. We have the buccolingual distance is very wide, and the maxillary sinus has also become very large, so we already know that for our crestal sinus lift, we either place a large amount of biomaterial, which is something I'm not particularly fond of, or we probably won't be able to achieve a complete lift. The entire maxillary sinus. At the same time, you don't see it here because to simplify things for tonight's webinar, I didn't include all the images, but you can see how this maxillary sinus shows a thickening of the membranes, which was evaluated, and then we saw radiographically. You will also see that this is due to an endodontic problem on one of the 2 teeth we will remove later on. So where did the mallet help us here? It simply helped us it allowed us, in a very simple way, to give stability to 2 implants, to perform 2 crestal sinus lifts with great ease, and to plan all the depths we needed to achieve. And we followed this during the surgery itself, so we removed the temporary bridge. Obviously, in this case, we raised a flap, placed our surgical guide, and here too, we reached the necessary depths. Now, one small thing I didn't mention. Obviously, when you go to perform a sinus lift, if you wanted to apply biomaterial, it's much easier to do this step without the surgical guide. So once we've reached the correct depth and felt the fracture of the sinus floor, it's always worth removing the guide and maybe using a blunt probe to check the membrane displacement of the sinus and then insert the biomaterial without the guide in the way, often for convenience, but this is my personal choice. I use elevators to carry the material inside because their concave shape helps me push it inside compared to the classic convex shape of instruments like the Black & Ruby, or in this case, the guided surgery instruments. So you can see the implant placement, a simple framework. Now let's look at the most important part, so the mix of guided surgery and bone condensation. So what we did is I'll show you what's called the superimposition of the initial plan with the final result. So by taking a follow-up CBCT, we then went on to superimpose the plan with the actual implant position. So the grey cylinder you see was the one that was planned, and the coloured implants are the actual implants in their position. I haven't put any measurements here, but this is the kind of difference you would expect typically with guided surgery. So, a discrepancy of about 3 to 5 degrees from the plan. Keep in mind that while for some this may seem a high value, the discrepancy between the plan and implant placement in freehand surgery is classically defined in the literature as being between 12 and 18 degrees, so about 5 times more than what we achieve using guided surgery. But that's the advantage of guided surgery. Now let's look at the advantage of using magnetodynamics. So we can see in the plan how our implant is protruding into the maxillary sinus by about 2 millimeters, and we can see what we already expected from the plan. So we have a very large maxillary sinus, and the implant is positioned more towards the palatal cortical plate. We performed a sinus lift, so with good osseointegration on the palatal side, whereas on the buccal side, we see we probably lifted the membrane incompletely, and so there's slightly less bone. This is absolutely not a problem. The implant has excellent stability, and we were able to load it with absolutely no problem. On the more mesial implant, however, we see a different process. Let me point out the change in the maxillary sinus. So on the left side in the plan, it was particularly opaque, whereas here it appears perfectly clear. Why? Because by removing the teeth that had infections, we resolved this small chronic inflammation in the maxillary sinus. So, returning to the advantage of using the mallet, we can see there is a thickening of the buccal cortical plate, which is always desirable in implant placement cases, because we know that maintaining a buccal cortical plate thickness of about 2 million is one of the things that ensures the long-term success of our implant. And at the same time, we can see how the approximately 3 millimeter of lift we wanted to achieve have been performed perfectly. The entire apex is perfectly integrated, and there is no visible difference in trabeculation between the native and the grafted bone. So, running a little ahead of schedule, as is my usual. My way of operating, we get to the key aspects of using the mallet. So, from the guided surgery perspective, the key for all of us is to acquire data correctly. Because planning is fantastic. It saves us time, makes us more precise. We gain a lot of things. But if it's not done meticulously, it automatically leads to an accumulation of errors that cannot be corrected during the surgery itself. Magnetodynamics involves another crucial detail that we must know how to interpret: bone analysis and understanding when our software, instead, like all software, is dumb and gives us values that are not real, but are simply related to anatomical situations that we will assess and modify during surgery. So, as we saw earlier, there's the case of an extraction socket, or the use of biomaterials prior to implant placement, and so on. Last but not least, what are the great advantages of magnetodynamics, and why do we like it? Because above all, I personally like it a lot for its use in extraction sockets, where I use it in almost 99% of cases. It guarantees that in almost 100% of cases, I can achieve a primary stability in low-quality bone, and where there's little bone, because clearly, after a tooth extraction, the percentage of cases where we already have residual bone sufficient to place an implant with drilling alone is very limited. The ability to modify its shape and ensure greater density allows me to place an implant rapidly, with a precise guide, therefore placing it in the most prosthetically driven way possible. This translates into less chair time, so the patient is definitely happy to reduce the total treatment time. But for us, it also translates into a better outcome, both aesthetic and functional, for our implant.